Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be doing another Kahoot. We're going to be covering more nursing exit exam topics. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now. Subscribe to my channel if you have done so already. And be sure to check out my website, nexusnursinginstitute.com. There you can sign up for a private one-on-one tutoring session. Maybe you want a private consultation session. You want to just pick my brain about something, or you need advice about something that has to do with the nursing field or nursing education. Or maybe you're preparing for your boards and you really need to prepare for your board. So you want to sign up for part one and part two, next generation NCLEX type review session. If you're a current nursing student, I have something available for you. Audio lessons. If you have to pass your next exam or you're going to get kicked out, right? You got to get really, really, really high on your next exam. Be sure to check out the audio lessons that I have available again on my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms such as TikTok, Instagram, Facebook, and of course, right here on YouTube. My handle's the same everywhere, Nexus Nursing. All right, guys, without any further ado, let's get started. Nursing exit concepts. All right, first question. So your patient is delirious. Which nursing intervention should be implemented? Are you going to move the patient next to the nurse's station? Are you going to brighten the lights in the patient's room? Are you going to turn off the television? Or are you going to play soft music? Again, your patient is delirious. Which nursing intervention should you perform? Wow. Wow, wow, wow. So 77 of you guys said move the patient next to the nurse's station. All right, let's talk about this. You have dementia and you have delirium. These are two different things, okay? A patient with dementia, which is not what we're talking about. I just want you to know the difference because dementia is another topic you very well may see on your exit exam. When a patient has dementia, dementia is progressive. As time goes on, it only gets worse. There is no cure. It's irreversible and it's insidious. It sneaks up on you. Okay. That's dementia. Delirium, on the other hand, is the opposite. It's acute. It happens immediately. Okay. And it is reversible. When you find that underlying cause, you can reverse it. Most patients that have delirium, they're delirious. Why are they delirious? There's an underlying cause, such as infection. Once you clear up that infection, they're not delirious anymore. They don't have that confusion, right? So it's reversible. It's acute. It's not progressive. Um, Here's the thing about delirious. The patient's delirious. They are confused. You want to decrease stimulation because stimulation increases the confusion. Okay. So even if you didn't know what the correct answer should have been, you kind of should have said to yourself, okay, there's one answer that's different than everything else. The first one, which 77 of you guys chose, move the patient next to the nurse's station. Well, what happens at the nurse's station? Nurses are giving report, they're taking report, they're asking questions, they're answering the phones, they're talking to family members, they're updating family members, they're talking to healthcare providers such as nurse practitioners and physicians, the fax machine's going off. There is a lot of activity going on in the nurse's station. And I just told you, any patient that's confused, that has anything going on with the brain, we want to decrease stimulation. So we're not going to have them next to the nurse's station where we have all that foolishness going on. 15 of you guys chose to brighten the lights in the patient's room. Again, because of that delirium, we want to decrease stimulation. So we're going to darken. We're going to darken those lights. We're going to turn off the TV. We're going to turn off the radio. We're going to close those blinds. We want to decrease stimulation. We're going to limit visitors because we don't want people going in and going out, going in, going out, talking to that patient all day, causing more confusion, right? And then 20 of you guys chose, excuse me, 15 of you guys chose about the bright lights, and then 20 of you guys chose to play soft music. They are delirious. We want to decrease stimulation. We're turning it off. Turn off all that stimulation, right? The correct answer, turn off the television, because we understand we want to bring everything down. We want to decrease stimulation. And so this is the concept I wanted you guys to understand about confusion or any type of disorder that can cause confusion, such as delirium, okay? How are you guys doing on the live? Thank you, Imran. Thank you. The code to get into the Kahoot, if you just joined, the code to get in is 965-765. 965-765. Next question. Which medication order would you question on the morning of surgery? So your patient's about to have surgery this morning, and you have an order for medication. Which one would you question? Would it be metoprolol? Would it be a levothyroxine? Would it be aspirin? Would it be fluoxetine? Which medication order would you question? Very good. Most of you guys chose the correct answer. Aspirin. Aspirin. Why? Aspirin can cause bleeding. Because aspirin's over the counter, people really don't understand how dangerous this medication is. The only reason it's still over the counter is just because it's been grandfathered in. And here in the US, it's all about this, right? But it's very dangerous. It can cause bleeding. And here's the thing. Here's another concept you guys have to know for testing purposes. Whenever surgery is mentioned, whenever an invasive procedure is mentioned, it doesn't matter what type of surgery we're talking about. It could be a mastectomy, it could be an appendectomy, it could be an amputation, it could be an arthroplasty, does not matter. If we're talking about surgery, your top three concerns are always going to be infection, deep vein thrombosis or pulmonary embolism, and hemorrhage, that patient bleeding out. So anything that can cause one of those three, that's what we're going to be concerned about. Okay? All right, moving on. Which goal is most appropriate for the patient with anxiety? Would it be suppression of those anxious feelings? Would it be identification of anxiety producing situations? Would it be continued contact with a crisis counselor? Or would it be eliminating all anxiety from daily situations? Which goal would be most appropriate for the patient that has anxiety? Very good. Most of you guys got this correct. Identifying anxiety producing situations, because you have to be able to identify those situations first, right? You have to know what actually causes those feelings of anxiety before you can do anything else, before you can actually help decrease that patient's anxiety. You have to be able to identify. You see that word identification? Let me tell you something. For testing purposes, if you are a student, listen to what I'm saying to you. Whenever you have a test and they give you scrap paper to write, the very first thing I want you to write before that test, as soon as they give you the scrap paper, I want you to write these three things. I want you to write ABC, airway, breathing, circulation. I want you to write nursing process, because this is what we're talking about first. You have to assess. You have to get information first before you can do anything else. This is our answer. And number three, I want you to write priority delegation / Maslow's hierarchy of needs. Guess what, guys? Most of your test questions are based on those three things that I just mentioned. If you can master those three things, I guarantee you're going to do so much better on your exams, right? So you have to identify, you have to get information first. You have to figure out what exactly is causing the anxiety before we can actually start to treat it, right? How can you figure it out? Asking questions. Assessment. Remember, assessment is not only a physical examination on a patient. Assessment is anything you do to get information. That's asking the patient a question. That's asking the caregiver a question. That's going into the patient's chart and looking up information. Anything that you do to get information is considered an assessment. Being able to identify. That word identification, when you see that, I want you to be able to think of assessment, because you have to do an assessment to be able to identify, okay? I'm sorry, I don't have enough characters on Kahoot to do case studies. Next question. All right, which preoperative lab should you immediately report to the healthcare provider? Would it be a platelet count of 121,000, glucose of 84, hemoglobin of 14.2, sodium of 140? Which preoperative lab value would you report immediately? You guys are doing great on the live. Very good. Platelet count of 121,000. All right. So go back to the question and where we talk about preoperative lab value. Didn't I just tell you whenever we talk about anything that has to do with operations, surgery, and invasive procedure, automatically the first three things that need to be going on in the back of your mind is infection, DVT pulmonary embolism, or what? Hemorrhage. So guess what? The fact that we're talking about preoperative lab values, let's get rid of glucose and sodium. Glucose 84, that's normal. Normal 71 to 110. Sodium 135 to 145. That's normal. That has nothing to do with those three that I just mentioned. Infection, hemorrhage, DVT, pulmonary embolism. That leaves platelet and hemoglobin, because if the hemoglobin's low, patient could be bleeding out. If the platelet's low, patient can be bleeding out, right? You agree? Yes, wonderful. When you look at the hemoglobin 14.2, that's within normal limits, but look at that platelet count. The lowest the platelet count should be is 150,000. This patient's 121,000. Platelets are needed for what? Aggregation, clotting. So because the platelets are so low, what are we concerned about? That patient bleeding. With a platelet count of 121,000, what do you think is going to happen when the patient gets into the operating room? They're going to bleed out on that table. So once you see that lab value, you're going to notify the surgeon immediately. All right, let's keep going. Next question. Your patient's been receiving levothyroxine for a year. Which lab value would you expect to find? Decreased T3, increased TSH, decreased TSH, decreased thyroid hormone. Your patient's been taking levothyroxine. By the way, you have to know this medication, okay? So they've been taking Synthroid. That's what this is, levothyroxine, Synthroid. They've been taking it for a year. Which lab value would you expect to find in this type of patient? Okay. Most of you guys chose the correct answer, decreased TSH, but a lot of you guys chose increased TSH. So I'm going to explain this once and for all because I notice students get very confused about this. Okay. So when it comes to the thyroid gland, so by the way, this medication like levothyroxine, Synthroid, it mimics the action of the thyroid gland, right? The thyroid gland, and I'm pointing to my throat because it's right here. It sits right here in your throat, right? The thyroid gland is responsible for those thyroid hormones. It's responsible for what? Metabolism. Okay. Um, a way to remember it, I tell my students all the time, I specialize in pediatrics. I'll have my pediatric patient come in and they'll be off the growth chart, way past the 95th percentile, right? And the first thing a parent will say, oh, their thyroid function is low. Because if thyroid function is low, that means the metabolism slow. If the metabolism slow, that means you're not burning calories, right? So what I will do beforehand, I will go ahead and let me get those labs. Let me get that thyroid function. Let me see what the TSH, a T3 and T4 is looking like. So let's get that out of the way, right? So here's the thing, guys. If your patient's been on levothyroxine for a year, they've been on a medication for a year that's supposed to be acting like the thyroid gland, right? What is the thyroid gland? It increases metabolism. With Synthroid, we see everything go up. We'll see the blood pressure go up. We'll see the heart rate go up. Everything goes up. We know that. All right. Now, if the patient's been taking levothyroxine for 1 year, we expect to see the thyroid hormones such as the T3 and T4 go up, but we expect to see the thyroid stimulating hormone, that's a TSH, go down. Let me explain to you why. If your thyroid gland is not working the way it's supposed to, brain says, whoa, we don't have enough thyroid hormone. We don't have enough T3, T4. So you're going to see increased TSH, thyroid stimulating hormone. The thyroid stimulating hormone is increased because we need more T3, T4. The T3, T4 is down. But as the T3 and T4 goes up, we don't need that much thyroid stimulating hormone. So what do we see happen? We see the thyroid stimulating hormone go down because it's not as needed. So the T3 and the T4 is always going to match whatever the thyroid gland's doing. So if the patient has hyperthyroidism, thyroid gland is working excessively, it's up. Guess what? T3 and T4 is going to also be up. Want to know what's going the opposite way? The TSH. Because if you have all this T3 and T4, why do you need TSH? Remember, TSH is thyroid stimulating hormone. It stimulates the thyroid hormone glands. We don't need it because it's already high. But if you have hypothyroidism, thyroid function is down, T3 is down, T4 is down, that's when you're going to see the TSH up because TSH comes onto the scene when we need more T3 and T4. So the T3 and T4 is always going to match what the thyroid gland is doing, and the TSH is going to be the opposite. So the fact that the patient's been getting levothyroxine, they've been getting Synthroid for a year, we expect to see the T3 and T4, those are our thyroid hormones, we expect to see those up, but the TSH, the thyroid stimulating hormone, we expect to see that down. Did I clear that up for you guys? All right, wonderful. I am your teacher. I'm your teacher on TikTok. All right. What's a complication of steroids being discontinued abruptly? Is it hyperglycemia? Is it adrenal insufficiency? Is it osteoporosis? Or is it decreased immunity? What is a complication of steroids being discontinued abruptly? Very good. Adrenal insufficiency, you can mess around and throw this patient into Addison's disease. So I want you to think about it. Let's talk about the other choices first, and I'll come back to the answer. So, and I did this on purpose, and some of you guys fell for it. The reason I put hyperglycemia, osteoporosis, decreased immunity, the reason I put those as options are because these choices, those are those are complications that may arise from taking steroids. Those are adverse reactions of steroids, but that's not what the question is asking you. I didn't ask you what's an adverse reaction of steroids. I didn't ask you what's a complication of taking steroids. What I did ask you was what's a complication of discontinuing steroids abruptly. You never discontinue steroids abruptly. It has to be tapered off, and I'm going to explain to you why. You're never going to forget, I promise. So your body makes, these hormones, they make the steroids, they make it naturally, right? Once you start taking these steroids, your brain tells the adrenal glands. Your brain says adrenal glands, and your adrenal glands say, "What's up, brain?" And brain says, "We're getting an exogenous source. We're getting an outside source. You don't need to produce all these steroids." And the adrenal gland says, "Okay, bet, I'm going to slow down." Right? And so the adrenal gland stops producing all of these steroids that your body was naturally producing before you were taking them, I can't speak. Exogenous, exo outside source. I can't say that word. Guys, you know what I mean, guys. If you're new, by the way, I'm sorry. If you're new, this is your first time watching me, I have a speech impediment. I've had it. Thank you. I've had it since I was a child. I've never been able to overcome it. So I apologize for that, but I'm trying my best. So anyway, the adrenal gland stops making as much steroids, right? Because you're getting that outside source. The E word I can't say. You're getting the outside source. So what happens is, for whatever reason, if you don't need to take that steroid anymore, you start getting tapered off. The dose gets smaller and smaller and smaller. What happens is your brain wakes up and says, "Whoa, we're not getting this outside source like we used to. Hey, adrenal gland." Adrenal gland says, "What's up?" And brain says, "You need to wake up. We're not getting that outside source the way we used to. You need to start shooting out more steroids, and adrenal gland says, okay, bet I got you, and it starts making more steroids. Wonderful. But if you don't taper, you just stop taking those steroids immediately, guess what? There's not enough time for the brain to contact the adrenal gland and say, hey, mayday, 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 we need more steroids. And guess what? You need this to live, right? It doesn't happen. So what happens is the patient goes into adrenal insufficiency. This is life threatening. This can kill the patient. So it's very important that the patient is always tapered off of a steroid. And if they're not tapered off a steroid, you need to understand that it can cause adrenal insufficiency. You also need to understand these other choices: hyperglycemia, osteoporosis, decreased immunity. This can happen to the patient from taking steroids. This is a complication. This is an adverse reaction, okay? All right, select all that applies. Your patient is on a low purine diet. Which foods will you teach the patient to avoid? Select all that applies. So your patient's on a low purine diet. Which foods are you going to teach your patient to avoid? Here are your choices: liver, sardine, wine, beef, soda, and shrimp. Which foods are you going to tell your patient to avoid if they are on a low purine diet? Those of you on my live, which diagnosis would you expect the patient to be on a low purine diet? Tell me. That's right, Kay Santos. Very good, Nat. If your patient has gout, you expect them to be on a low purine diet. Very good. Very good. Correct. Because of uric acid. Correct. Okay. Let's see. And guys, the correct answer is all of these. Patient on a low purine diet shouldn't have any of these. Um, Organ meats, such as liver, kidney, they shouldn't be having. Seafood, shrimp, sardines shouldn't be having. Wine, beef, soda, and let me tell you why soda. That sugar, the fructose that's in the sodas, those sugary drinks, increases purine. Okay, so make sure you guys know all of these different types of foods that you would teach the patient on a low purine diet or the patient with gout to avoid. All right, you have an order for 5 grains of aspirin. That's what you have to give. But the medication is only supplied in milligrams. How much are you going to give? So you have to give 5 grains of aspirin to your patient, but it only comes in milligrams. How many milligrams are you going to give the patient if the healthcare provider wants 5 grains? Go ahead, pull out your calculator, pull out your pencil and paper, do the math. Come on. Okay, good. Most of you guys chose the correct answer, although a lot of you guys didn't even answer. The correct answer is 325, approximately 325. Here's what you have to remember. 1 grain is equal to 60 milligrams. So if 1 grain is equal to 60 milligrams, 5 grains equal what? So when you do your 6 times 5 gives me 30, but then you have to also add the 0. That's 300. The closest thing we have here to 300 is 325. That's what you're going to do. Okay. Make sure you guys know that 1 grain is equal to 60 milligrams. All right. There are 5 A's in smoking cessation. Which one's the first? Advise all smokers to stop. Ask all patients about tobacco use every visit. Assess all smoking patients' willingness to quit. Assist all smoking patients to quit. Which one's the first? Wow. 53 of you chose assess all smoking patients' willingness to quit. Let me ask you a question. How do you know if they're a smoker unless you ask them first? You're telling me the first thing that you're going to do is assess all the smoking patients' willingness to quit. How are we going to know if they're a smoker or not if we haven't asked them yet? Now, I'm proud of you. At least you understood, okay, we're going to assess first. So you should have been between blue and yellow because blue and yellow are both assessment questions. Asking questions, that's an assessment. Assessing, that's an assessment. You should have been between blue and yellow, but you cannot get to yellow without the blue. So the first thing you're going to do is ask all patients about tobacco use every single visit. Because guess what? You may not be smoking today, but when you come back next week, you may have started smoking. So every visit, I'm going to ask you, have you started smoking? Are you a smoker? Okay. I have to identify those who are smokers before I can even identify their willingness to stop smoking. And that's how you're supposed to be thinking on these test questions, guys. It's simple little things like that that will get you. You'll know the answer, but you just have to take it a step further. Why are you guys laughing at me on the live? Are you laughing at me? Okay, next question. Select all that applies. All right, your patient has a mild anoxic brain injury resulting from a previous myocardial infarction. Which symptom would you expect to see? Select all that apply. So I'm going to repeat this. Your patient has a mild anoxic brain injury that resulted from a previous MI. So they had a heart attack. The heart attack caused them to have a mild anoxic brain injury. Which symptoms would you expect to see in this type of patient? Select all that applies. Decreased level of consciousness, increased level of consciousness, seizures, memory loss, decreased balance, restlessness. Select all that apply. All right, so let's talk about it. Correct on decreased level of consciousness. So the patient had a mild anoxic brain injury. That brain has gone without what? Oxygen. We're concerned about what? Tissue death, right? So we're going to expect to see decreased level of consciousness, maybe confusion, maybe lethargy, right? But we expect to see a decreased level of consciousness, not increase. And by the way, guys, whenever you see two opposite, you better not choose both. It's going to be one or the other. How can both be correct if they're opposites, right? We expect to see decreased level of consciousness. Why? We're seeing decreased brain function. Speaking of decreased brain function, next, it's not going to be seizures. You know what seizures are? Seizures are when the brain function goes into overdrive. We're seeing hyperactivity of the neurons, but that's not what's happening here. The patient had what? Anoxic brain injury. So we're not expecting to see seizures, but we are expecting to see memory loss, absolutely. Decreased brain function. Balance, decreased balance, absolutely. And of course, restlessness. Let me explain to you about restlessness. When you see that word restlessness or anything that describes restlessness, because for testing purposes, it may not say restlessness. You may get a description of that patient being unable to sit still, or, the English language has a million words that mean the same thing. So if English isn't your first language, make sure you Google the synonyms for restlessness. But when you see the word restlessness or anything that describes restlessness, I want you to think of decreased oxygen to the brain. That is the number one cause of restlessness, decreased oxygen to the brain. Okay. All right, next question. We're almost done, guys. Select all that apply. What are the risk factors for the development of type 2 diabetes? Select all that applies. What are the risk factors for type 2 diabetes? Here are your choices. Obesity, emaciation, hypertension, being 45 years or older, having a family history of diabetes, being Caucasian or white. What are the risk factors for the development of type 2? We're not talking about type 1, type 2 diabetes. All right, come on, guys. I know there's more than 65 of you guys on this Kahoot. Don't be shy. All right. Risk factors. Yes, obesity. That is a risk factor. And again, look at obesity and emaciation. Those are complete opposites. Obesity, and then when a person's emaciated, they're wasting away, right? So again, whenever, if you guys don't know what the answer is and you see two opposites, choose one, but don't ever choose both. So yes, obesity is a risk factor for type 2 diabetes. Hypertension, absolutely. And not only hypertension, let's just anything that falls under excuse me, heart disease. That's going to be a risk factor for type 2 diabetes, including hypertension. Being 45 years or older, absolutely. I want you to think of it this way. The longer that you've been on this earth, you've had more time to eat the things you shouldn't be eating, such as those cookies and cakes and everything else. So your risk goes higher for diabetes. And not only that, the older that you get, very often your body's more resistant to the insulin that produces. That's also a possibility as well. Family history. Absolutely. Caucasian race? No, actually, being Black, African American, African race, that's a risk factor, but not Caucasian. Excuse me. All right, one more question. Select all that applies. Which diagnosis makes you question a drug order for levodopa? So you have a drug order for levodopa. Which diagnosis would make you question that drug order? Here are your choices: narrow angle glaucoma, macular degeneration, pregnancy, melanoma, cataracts, Parkinson's. Which patient diagnosis would make you not give this med? You have the order to give it, but you looked in the patient's chart and you see this diagnosis or these diagnoses, and you're like, I'm not going to lose my license. Let me call the healthcare provider and find out if they are aware that the patient has this diagnosis. Because if they are and they tell you they still want you to give this medication, you want to know what you say? You tell them to come down and give it to the patient themselves. Let me tell you something. When you're the nurse that knows his or her stuff, you can talk to the healthcare provider that way because you are not putting your license at risk. And when you know your stuff, guess what? The healthcare provider be like, you know what? I'll call you back. And they're going to change that order. They're not trying to lose their license either. All right. So which are contraindications? That's the word I was looking for. Which diagnoses are contraindications for giving levodopa? By the way, guys, this medication levodopa, that's for, the patient that has Parkinson's. We give this for a patient with Parkinson's disorder. When it comes to Parkinson's, by the way, this is something else you have to know for exit exam. The problem with Parkinson's is decreased dopamine. That's the problem. Decreased dopamine. So we would give levodopa, which will increase the dopamine level. Okay, now that we got that out the way, which are the contraindications? And they are narrow angle glaucoma, if that patient's pregnant, or they've got melanoma. We are not going to give that medication. We're going to withhold it and call the healthcare provider. All right, guys, let's see how you guys did.